Part 5 of Non-Intentional Childhood Injuries is going to discuss drowning and near drown. In Orange County and the San Diego County area, drowning is one of the leading causes of death under age 4, and as we saw in the very first lecture, it's happening way too frequently. So the patho behind the near drowning, actually drowning, would be swallowing in water, panicking. They can vomit and aspirate. They can just suck the water in. They have hypoxia. They have cardiac arrest. That leads to brain cell death. And this can be a dry drowning, but they had a lot of laryngospasm. Therefore, there's no oxygenation. And we still end up with hypoxia, cardiac arrest, and brain cell death. So this is a very complicated slide of the pathophysiology of drowning. I would suggest that you put the video on pause so that you can really sit there and look at the algorithm that's in the lower left corner, because it gives you a very good idea of the cascade of events that happens that leads to the profound brain injury that occurs with a near drown. Drowning, it's death. And that's why, even though we say it's drowning, if we have a child that is in our midst that we are taking care of, they're a near drowned. Because if they've fully drowned, they are gone. But we work very hard on these kids. And we might be doing CPR on them for an hour, and we actually can resuscitate them. But their quality of life is never going to be what it was prior to the event. So irreversible brain damage occurs after 4 to 6 minutes of submersion underwater. Severe hypothermia may provide a little bit of breathing room here because everything slows down in that very cold water, and so we might be able to have a kid who comes out of it after 10 minutes just because they were so hypothermic. But the pre-hospital research studies show prolonged full arrest leads to death or severe brain damage. But if we can initiate CPR and get return of spontaneous circulation right there at the scene, we have a better outcome. And of all the near drowned kids that I have taken care of, I have only had one who walked out. He had post-traumatic stress as a result of his near drown, but there was no damage. All the other kids that I've taken care of, they have irreversible brain damage and they're never the same. And it totally destroys families. So we have a hypoxic event that leads, of course, to cellular damage. As the cells are damaged, they swell. They can also rupture. But because of this swelling of the tissue, there's an increase in the intracranial pressure. This increase puts pressure on the cerebral blood vessels, so there's a decrease in flow. That flow leads to cellular hypoxia and then eventually death of those cells. So it's a vicious cycle. There's more edema, more increased intracranial pressure, decreased flow, and it just keeps spiraling downhill. In addition, we have hypoventilation. So we have an increase in the CO2 and a decrease in the oxygen level. This causes the body to vasodilate. We have more increase in intracranial pressure, and now we have brainstem compression because we have two pathways that are causing this increase in pressure. Pressure on the brainstem further compromises the respiratory system, so now we have respiratory depression. Oxygen goes down further, CO2 retention is greater, there's more vasodilation, and then eventually we have herniation of the brainstem and eventual death. Caring for children with a submersion injury is very difficult, and part of it is because whoever was responsible for watching the child has so much guilt, and there can be family strife among these individuals. So one person who was responsible is guilt, and the other person is blaming. So these children are going to be in ICU or in a step down. They're very rarely put right on a pediatric floor. And the reason they're in ICU is because we do need neurologic resuscitation, and if they have multi-system organ failure, we have to support respiration. We are supporting their blood pressure so that they can perfuse and we can reoxygenate that brain and the vital organs as much as possible. The psychosocial care is huge, so you are going to be taking care of the family in addition to the child. There is disbelief that this happened, especially when it happens in front of a whole bunch of adults who were supposed to be eyeing the kid, but they were distracted doing something. And this is the usual. Only 10% of kids who drowned are totally unsupervised. All the rest are parents, babysitters, other siblings around that actually took their eyes off of the kid, and that's when it happened. There are a lot of stages of grieving where at the beginning it's hope and pray, hope and pray, hope and pray. And they will just grab onto any little positive movement or moan or sigh by this children, and they will think, oh, they're coming out of it. There's also ethical legal issues because we may have to make that very difficult decision of when do we take the child off of life support. So you can see it's very intense psychosocially. Our nursing care focuses on assessing their breathing rate, their effort, and hypothermia. So what were they like when they first came in, and then how cold was the water? The longer they're down in super cold water, we still have extra time to resuscitate them. Respiratory support. These are kids who you are going to listen to their breath sounds and hear coarse crackles and rhonchi all the time. They may develop atelectasis where there's complete collapse, and these kids will develop pulmonary edema because of the type of water that has been inhaled into the lungs. They will develop pneumonia at some point, but it's not going to be for a couple of days. That pneumonia doesn't kick in the first 24 hours. Monitor their circulation, their heart rate, their pulse ox. You're going to put them on a cardiopulmonary monitor. Monitor their hydration status because they already have coarse crackles and rhonchi, and they're at risk for the pulmonary edema. So we are going to be very careful and cautious about giving them IV fluids because we don't want to tip them into more respiratory distress. I would say once we know that this kid has a pulse, the two areas that are your biggest focus is going to be the lungs and their neurologic system. So neurologically, are they responsive to your talking? Are they responding to touch? What do we have to do to get them to respond to pain? What are their pupils doing? And so these will be children that you will see their pupils fixed and dilated. And they can have nystagmus. What kind of movement are they having in their extremities? Is any of it purposeful? And eventually, depending on how much hypoxia the brain has sustained, they can become decorticate, where their hands and feet are moving towards the core, or decerebrate, so their hands and feet are moving out. And there's excellent pictures in your textbook of these two postures. We give them fluids. We do have to monitor their sodiums when they were in fresh water because of the fluid shift from the external water coming internally. Monitor their urine output because of the shock that they go into, poor perfusion to the kidneys, and decrease in the excretion of fluids. We do want to give them an IV, and sometimes it's very temporary, 1 or 2 days, and then it's out. But we're going to put a G-tube in these kids because they still do need to eat. So initially we'll put an NG tube down, and then they'll switch them over to a G-tube, and you'll be giving feedings. We don't anticipate this child to develop an infection for about 3 to 5 days, and it's going to be in the form of a pneumonia. If the gut has been compromised, remember when there's hypoxia, it's all over hypoxia, so it's going to hit all of the organ systems, and it's also going to hit the GI tract where it becomes hypoxic, doesn't function that well. And we want to monitor that they do have stools, that they have bowel sounds, that they're not distended. And then they can't eat, so we will give them support. Give the family and the significant others as much support and privacy as possible. We want social services to come in and talk to them. We can have psychologists come in and talk to them. Child Life will be very intimately involved. And then eventually these kids are going to go to rehab. And even when you have a child who has fixed dilated pupils, they're not responding to any pain, they are still resilient. So don't write them off in those first few days, because 2 weeks later, all of a sudden they start coming out of it and they are amazing. Are they going to be normal? No, they're not. But there is potential for recovery. One of our best things that we can do for children is prevention of drowning. Very important. So on our anticipatory guidance, when you see that one of the leading causes of death in the 1 to 4-year-olds is drowning, that's our job, because they can drown in a bucket of water, they can drown in a dog's water bowl, they can drown in a toilet. We don't put any fences around those blow-up pools, and it's very easy for a toddler to just walk around and run into it. It's very soft. They go in head first and they can't get themselves out of it. So the recommendations by the American Academy of Pediatrics is to have 3 barriers. Have a gate with a self-closing latch, and I believe that is a law that if you have an in-ground pool, you have to have a high fence that the kids can't go over. They want the gate, a secure cover, not one of those flimsy ones, but when you look at the picture in the middle, there's a kid who is on a really good cover, that it's sealed so it's hard. You don't want a soft cover because the kids are going to get on top of it and they're going to fall right through. And then providing real supervision, not half supervision. When the kids are in the pool, the adults need to be watching the children and account for every one of the children at all times. Chalk Hospital has a drowning prevention program, and they recommend that there's a designated person who is a pool watcher with ID tags. Isn't that amazing? So this ends the lecture on drowning and near drown.